Good evening, friends. I am very happy to be present virtually during this CCDSICON 2022 6th annual conference being held at Goa. I am unable to present myself physically, so I am presenting myself virtually. I am very much thankful Dr. Anil Kumar Virmani, President-elect, Organizing Chairman, and Dr.A.N.RAI, Founder President of CCDSI and Doyen of CCDSI, Dr. Arul-Raj, President, other presidents, Dr. Jayant Panda, Dr. Kaitan, K.M. Shankar Sharma, and all faculties and dignitaries. I am very happy Dr. Jayant Panda and Dr. Ashok Tanaja are chairing my session, Dr. A.N.RAI's oration, Diabetic Nephropathy, my current updates. So, and they are arranging in a grand manner. So, I happy that most of you are being present physically. And let us go one by one. So, the current updates, diabetic nephropathy, what is new, we will see. So we all know diabetic nephropathy is a clinical syndrome. It is characterized by the presence of persistent albuminuria more than 300 milligrams per day or more than 200 microgram per minute that is confirmed on at least 2 occasions, 3 to 6 months apart. And there is progressive decline in the glomerular filtration rate, and there is elevated arterial pressure. We all know the microalbuminuria is as low as 30 to as high as 300 milligram per day, and as low as 20 microgram, as high as 200 microgram per minute. That is microalbuminuria, we all know that. So the proteinuria first recognized in 1930, Kimball Steele Wilson described this classic lesions of nodular glomerular sclerosis in diabetes associated with proteinuria and hypertension. Way back in 1950, the kidney disease was clearly recognized as a common complication of diabetes, with as many as 50% of patients with diabetes of more than 20 years having these complications. Currently, diabetic nephropathy is the leading cause of chronic kidney disease in US and other Western societies. It is one of the most significant long-term complications in terms of morbidity and mortality for individual patients with diabetes. So diabetes is responsible for 30 to 40% of all end-stage renal disease in US. Diabetic nephropathy in general, considered after routine urine analysis screening for microalbuminuria in the setting of diabetes. Patients may have physical findings associated with the long-standing diabetes mellitus. There is good evidence suggesting that early treatment delays or prevents the onset of diabetic nephropathy or diabetic kidney disease. That is being consistently shown in both type 1 and type 2 diabetes mellitus. What is atypical diabetic nephropathy? This is a recent one. The diabetic nephropathy with the dissociation of proteinuria from reduced kidney function. It is also noted that microalbuminuria is not always predictive of diabetic nephropathy, yet a majority of cases of diabetic nephropathy presents with the proteinuria, which progressively gets worse as the disease progresses and is almost uniformly associated with hypertension. The three major histological changes: first, mesangial expansion, directly induced by hyperglycemia, that is by increased matrix production or glycation matrix proteins. Second one, thickening of glomerular basement membrane. Third, glomerular sclerosis, that is by intraglomerular hypertension induced by dilatation of afferent renal artery or from ischemic injuries induced by highly narrowing of the vessels supplying the glomerulus. These different histological patterns appear to have similar prognostic values. The key change in diabetic nephropathy is augmentation of extracellular matrix. The earliest morphological abnormality in diabetic nephropathy is thickening of glomerular basement membrane and expansion of the mesangium due to accumulation of extracellular matrix. The pathogenesis, the light microscopic findings, what is that show? There is increase in the solid space of the tuft, most frequently observed as coarse branching of solid, that is positive periodic acid shift reaction material, that is diffuse diabetic glomerulopathy. There is large acellular accumulation that is being observed within these areas. They are rather circular on section and known to be called as Kimmel-Steele-Wilson lesions or nodules. The immunofluorescence microscopy, they reveal deposition of albumin, immunoglobulin, fibrin, other plasma proteins along glomerular basement membrane in a linear pattern. It is most likely due to exudation from the blood vessels, but that is not immunopathogenic or diagnostic and does not imply an immunological pathophysiology. The renal vasculature typically displays the evidence of atherosclerosis, usually due to concomitant hyperlipidemia and hypertensive atherosclerosis. The EF electron microscopy provides rather a more detailed information of the involvement of structures. In advanced disease, the mesangial regions occupy a large proportion of the tuft with a prominent matrix content. Further, the basement membrane, the capillary walls, that is the peripheral basement membrane, is thicker than normal. So diabetic nephropathy, the severity is estimated by thickening of the peripheral basement membrane, mesangium, and matrix expressed as a fraction of the appropriate spaces. For example, volume fraction of the mesangium bar glomerulus, matrix bar mesangium or matrix bar glomerulus. The diabetic nephropathy from and versus chronic renal insufficiency. The glomeruli in kidneys are typically normal or increased in size initially, distinguishing diabetic nephropathy from most other forms of chronic renal insufficiency, wherein renal size is reduced except renal amyloidosis and polycystic kidney disease. And then over to diabetic nephropathy and hypertension. In addition to renal hemodynamic alterations, patients with overt diabetic nephropathy, that is dipstick positive proteinuria and decreasing GFR, generally develop systemic hypertension. So hypertension is an adverse factor in all progressive renal disease and rather seem especially so in diabetic nephropathy. The deleterious effects of hypertension are likely directed at the vasculature and microvasculature. The hypertension association, that is obesity, metabolic syndrome, and diabetes, they all play an important role in the pathogenesis of diabetic nephropathy. Central obesity, metabolic syndrome, and diabetes lead to increased blood pressure. Central obesity induces hypertension initially by increasing renal tubular reabsorption of sodium, causing a hypertensive shift of renal pressure natriuresis through multiple mechanisms, including activation of sympathetic nervous system, renin-angiotensin-aldosterone system, as well as physical compression of the kidneys. And last but not least is hypertension, along with the increase in intraglomerular capillary pressure and metabolic abnormalities, example dyslipidemia, hyperglycemia, likely interact to accelerate renal injury. The diabetic nephropathy features, there is associated obesity, associated glomerular hyperfiltration, renal vasodilatation, increases in the glomerular filtration rate and intraglomerular capillary pressure, and increased BP are all characteristic features of diabetic nephropathy. Increased systolic blood pressure further exacerbates the disease progression to proteinuria and a decline in GFR, leading to end-stage kidney disease. The etiology exact cause is unknown, but various postulated mechanisms, hyperglycemia causing hyperfiltration, renal injury, advanced glycation products, activation of cytokines. Many investigations now agree diabetes is an autoimmune disorder, overlapping pathophysiologies contributing to both type 1 and type 2, and recent research highlights the pivotal role of innate immunity. One is toll-like receptors, another is regulatory T cells Treg. So the mechanism is hyperglycemia, is it? Glycemic control reflects the balance between dietary intake and gluconeogenesis and tissue uptake or utilization through storage as glycogen or fat and oxidation. This balance is rather regulated by insulin production from beta cells of the pancreas. Insulin regulates serum glucose through its action on liver, skeletal muscle, and fat tissue, that is insulin-sensitive tissues. When there is insulin resistance, insulin cannot suppress hepatic gluconeogenesis. We all know that leads to hyperglycemia. Simultaneously, insulin resistance in the adipose tissue and skeletal muscle lead to increased lipolysis and reduction in disposal of glucose, causing hyperlipidemia in addition to hyperglycemia. What are the cytokines, the inflammatory mediators? That is, whenever there is insulin resistance, the pancreas is forced to increase its insulin output, which stresses the beta cells, eventually resulting in beta cell exhaustion. So what happens? The high blood glucose levels, high levels of saturated fatty acids create an inflammatory medium, resulting in activation of innate immune system. That results in activation of nuclear transcription factor kappa B, NF-kappa B, and release of inflammatory mediators, that is interleukin 1B, tumor necrosis factor alpha, promoting systemic insulin resistance and beta cell damage as a result of autoimmune insulitis. So hyperglycemia, high serum levels of all these cytokines, they result in apoptotic beta cell death. And another thing is the transforming growth factor TGF-B, another beta. Another is vascular endothelial growth factor, again stimulated by the cytokines. So this TGF-beta and VEGF may contribute to the cellular hypertrophy, enhanced collagen synthesis. They rather induce the vascular changes observed in persons with diabetic nephropathy. So hyperglycemia also may activate protein kinase C, which may contribute to renal disease and other vascular complications of diabetes. The familial perhaps even genetic factors play a role. Certain ethnic groups, African Americans, Hispanic American Indians, they are all particularly disposed to renal disease as a complication of diabetes. We all know it is very much frequent, that is genetic predisposition diabetes in Western societies, even more so in minorities, reflect the fact that in the past insulin resistance conferred a survival advantage, the so-called thrifty genotype hypothesis. What is polymorphism? Evidence accrued for a polymorphism in the gene angiotensin converting enzyme in either predisposing to nephropathy or accelerating its course. However, definitive genetic markers have yet to be identified. More recently, the role of epigenetic modification in the pathogenesis of diabetic nephropathy has been highlighted. We all know that is folic acid DM nephropathy, that is by Berwani et al. That is, they have identified the low folic acid always increase the risk of diabetic nephropathy. That is important point to be noted. And epidemiology 1950, it has been clearly recognized that is kidney disease, common complication of diabetes mellitus. As many as 50% of patients with diabetes mellitus of more than 20 years duration having this complication. So the risk of diabetic nephropathy, the diabetic nephropathy is low in normoalbuminuric patient, the risk with the diabetics duration of greater than 30 years. Whereas patients who have no proteinuria after 20 to 25 years have a risk of developing overt renal disease of only approximately 1% per year. In terms of diabetic kidney disease, in US, the prevalence increased in 1988-2008 in proportion to the prevalence of diabetes. Among people with the diabetes, the prevalence of diabetic kidney disease remains stable. So there is international statistics, that is in Germany and also in US and other countries, there is increasing diabetic nephropathy. And also in China, that is Fan Wang et al. That is in diabetic patients type 2, there is high prevalence of non-diabetic renal disease. They have investigated in many patients the incidence of NDRD who underwent the renal biopsy. They have identified this diabetic nephropathy that is being complicated, that is NDRD, non-diabetic renal disease. Membranous nephropathy, immunoglobulin A nephropathy, and focal segmental glomerular sclerosis were the most common non-diabetic renal disease. You have to note it. Sex distribution, both affects males and females equally. Age distribution, diabetic nephropathy rarely develops before 10 years duration of type 1 diabetes, whereas the peak incidence, 3% per year, usually found in persons who have had diabetes for 10 to 20 years. The mean age of patients who reach end-stage kidney disease is about 60 years, elders. Although in general, the incidence of diabetic kidney disease is higher among elderly patients who have had type 2 diabetes for a longer generation. The role of age in the development of diabetic kidney disease is unclear. In PIMA Indians with the type 2 diabetes, the onset of diabetes at a younger age was associated with high risk of progression to end-stage kidney disease. The prevalence by race, again, in blacks high, Mexican Americans high, PIMA Indians with type 2 diabetes, that is about 3 to 6-fold. So the frequency of the condition is a genetically disparate population, suggests socioeconomic status, that is factors. What are they? Diet, poor control of hyperglycemia, hypertension, obesity. They all play a primary role in the development of diabetic nephropathy. It also indicates that the familial clustering occurring in these populations. So age prognosis, that is age 20 years, as many as of all PIMA Indians with diabetes have developed diabetic nephropathy. 15% of these individuals have progressed end-stage renal disease. Diabetic nephropathy accounts for significant morbidity and mortality. Proteinuria is a predictor of morbidity and mortality. The overall prevalence of microalbuminuria, macroalbuminuria in both types of diabetes is approximately 30 to 35%. Microalbuminuria independently predicts cardiovascular morbidity. Microalbuminuria and macroalbuminuria increase mortality from any cause in diabetes mellitus. Microalbuminuria is also associated with the increased risk of coronary peripheral vascular disease and death from cardiovascular disease in the general non-diabetic population. The proteinuria and mortality, the patients in whom proteinuria has not developed have a low and stable relative mortality rate, whereas patients with the proteinuria have 40-fold higher relative mortality rate. Patients with type 1 and diabetes with the proteinuria characteristic the so-called bell-shaped relationship between diabetes duration, age, relative mortality, maximum relative mortality in the age interval of 35 to 38 years, that is reported 110 females and 80 males. The end-stage renal disease major cause of death, about 59 to 66% with the type 1 diabetes mellitus with the nephropathy. In Germany, it is noted 5-year survival rate, less than 10 years in the elderly population with the type 2 diabetes, and now more than 40% in the younger population with the type 1 diabetes mellitus. So the cumulative incidence of end-stage renal disease in patients with the proteinuria and type 1 diabetes is 50% 10 years after the onset of proteinuria, compared to the 3 to 11% 10 years after the onset of proteinuria in European patients with type 2 diabetes mellitus. There are so many studies. Zhang et al. Suggested the presence of diabetic retinopathy, independent risk factor, and they have indicated higher number of comorbidities. Type 2 diabetes increase the likelihood of diabetic nephropathy will progress. So all these studies show that is the risk of diabetic nephropathy. So other studies, Rosolowski study, they also show the increased risk of diabetic nephropathy of longer duration, especially associated with microalbuminuria, macroalbuminuria. Cardiovascular disease, major cause of death, 15 to 25% in patients with the nephropathy and also type 1, despite the relative young age. Metformin renal disease, what are the current recommendations? We all know can be continued till eGFR 30 ml per minute. The reason, it is observed, many large observation studies, hundreds of thousands of patients, there are extremely few adverse outcomes in patients with metformin until the creatinine clearance is below 30. So what do I do? What do many people do? Suppose there is 30 to 45, it drops down to 45. That is between 30 to 45. Dose we can reduce it to half, 1000 twice daily, perhaps 500 milligram twice daily. So, and of course, patients who have unstable renal function, who are at risk of acute kidney injury, who are at risk of infection, and have rapid change in their clinical status, caution is warranted, perhaps increased monitoring or even discontinuation of metformin. So 35 to 40 eGFR. So what, not only it is safe to continue metformin, it can be safer to continue metformin than it is to select an alternative lowering medication. So there are new biomarkers. Let us see what are the new biomarkers. So the tubular biomarkers also, they are called non-albuminuric diabetic kidney disease apart from albuminuria and non-albuminuric diabetic kidney disease. They are cystatin C, kidney injury molecule 1 microglobulin, N-acetyl beta-T glucosaminidase, liver type fatty acid binding proteins. But their advantage over microalbuminuria are evidence-based, majority still need to be validated. This is 2018. So another new biomarker, that is a zinc alpha-2 glycoprotein. It is also a useful biomarker as an early biomarker for detection of diabetic nephropathy, type 2 diabetes earlier than microalbuminuria. This is 2019. So there are so many traditional studies. They are showing a recent crosstalk between tubular epithelial cells and glomerular endothelial cells. So they are close to each other. We all know TECS and glomerular endothelial cells, GECS, each other, an anatomical position. Crosstalk with each other, so they may affect the development of diabetic kidney disease. That is the main cause of diabetic kidney disease. So improving the injury to the that is the tubular epithelial cells and glomerular endothelial cells, and maintaining normal crosstalk between them may become a new strategy for the prevention and treatment of diabetic kidney disease in future. So we have to prevent this one and find out the progression of crosstalk between these cells. This is the one, the role of parathormone, then the reactive oxygen species, glomerular endothelial cells, tubular epithelial cells. This is the diaphragmatic. This is the diagrammatic representation. So CKD and DKD, we have to recognize there is also an entity of CKD, a diabetic kidney disease without microalbuminuria, that can be just as problematic and something really to be concerned about. You don't always get the warning sign of microalbuminuria before a patient's progress to more advanced diabetic kidney disease. The entity of diabetic kidney disease without microalbuminuria is an increasingly prevalent problem and just as a concern. So the medications, ACE inhibitors, angiotensin receptor blockers, amelioration of diabetic nephropathy, SGLT2 inhibitors, yes, they play a vital role and they decrease the intraglomerular pressure and also decrease the afferent arteriolar vasoconstriction. So they are really protecting glomerulus against the hyperfiltration that is seen in diabetic kidney disease. And as people probably know, a blockade of renin-angiotensin system leads to dilatation of the efferent arteriole, which also decreases the pressure in the macula densa. So there is a possibility that combining these two drugs could lead to decreased pressure across the glomerulus and is rather very protective in restoring the normal physiology in people with diabetic kidney disease. We all know the creatine bump. We see a creatine bump in the use of angiotensin receptor blocker, use of SGLT2 inhibitors, a physiological increase in creatinine that is related to decreased GFR, but that really represents is sort of functional improvement in the pressure across the glomerulus. It is very hard to tell whether that represents a true acute kidney injury or in fact that intended goal of therapy. Therefore, it is important carefully monitor these patients on dual blockade, but that over the long term, when used properly, this has been seen in clinical trials that have benefit on diabetic kidney disease and offers very exciting potential. So there are so many guidelines and we have already highlighted. There is a lot of factors playing kidney disease progress, insulin resistance increase. So the insulin clearance decreases as kidney disease progress. So it really can be quite hard to predict whether one needs to increase or decrease the insulin. Very important. Why? Because the small increase in creatinine dramatically increase the risk of hypoglycemia because the kidney is responsible for 30% of gluconeogenesis. We all know. Monitoring the patient, having the patient do careful self-monitoring, making sure and make them to understand how to adjust his or her own insulin in anticipation of changes in diet and activity is the most important strategy. Another new biomarker is angiopoietin-like protein. It is a circulating pro-inflammatory protein. That is again, it is related to podocyte dysfunction independently associated with the progression of diabetic kidney disease. This is 2019. This is a quiz that is a urine clustering. Urine clustering in diabetic patients, eGFR is more than 60 ml per minute, 1.732 correlates with both answers as correct. Second, neither answer is correct. Development of CKD stage 3 or greater, persistent or progression of albuminuria. So both answers are correct. How? The increase of urine clustering along with albuminuria could be an independent predictive marker for the progression of diabetic kidney disease in type 2 diabetes. This is an exercise. We all know the neprilysin inhibitors in CKD, Tejas P. Desai, that is the new thoughts on neprilysin inhibitors, that is, they also play a vital role in diabetic kidney disease and it shows some renal protection. And are also clustering of diabetes, we all know SID, SIRD, MOD. What is to be noted? Cluster 3, high degree of insulin resistance, higher risk of diabetic kidney disease. Whereas the severe insulin deficient cluster had a high risk of diabetic retinopathy. That is the clustering found out by Emma Alquist. This is cigarette smoking and all. Again, there is associated of increased cigarette smoking, the risk of diabetic nephropathy. That is my mnemonics, that is CAM, 2C, 2A, 2M. That is Cockcroft-Gault formula and chronic epidemiological kidney disease formula. Another is 2A, age-related formula. Another is A is Prabhat Agarwal formula. Another is modified diet renal disease formula and Mayo quadratic formula. So the very important thing is MDRD and Cockcroft-Gault formula are the most widely used formula you can find out in your Play Store in iStore. This is a very important formula. That is a CAM is a machine that unites two machines. This is my mnemonics. So I have highlighted this diabetic nephropathy. This is the familiarity, the estimation of eGFR from serum creatinine measurements. That is about 15,612 patients in the Diabetes University of Utah Health Center established the renal function trajectories. So the familiarity, the familial analysis showed that rapid renal decline aggregating in these families associated with the increased risk among first-degree relatives. Please note it. Further study of these families necessary to understand the magnitude of the influence of shared familial factors, including the environmental and genetic factors on rapid renal decline in diabetes. Thank you very much. We have highlighted the diabetic nephropathy current views. And I am very much thankful. Dr. Mrityunjay also, they are very active organizing secretary. I am thankful to Dr. Anil Kumar Virmani. He is in constant touch with me, Dr. A.N.RAI, and all the dignitaries, all the faculties. Thank you very much.